hospital had recently deployed tele-ICU, so they made that first wave of transformation to recognizing that you can have other care members on your team virtually, because they had been in the tele-ICU model for about a year and a half. So we have not yet deployed. We, hopefully by Friday, good grief, will finally get the contracting signed. But I will tell you, to sell this, I had initially talked about just really learning from these two fine leaders, understanding what your enhancements, your deliverables for improving patient experience, reducing turnover, improving your quality. I approached it to the rest of our team as really a quality improvement project, that we can transform care, have, again, nurses working at the top of their license, add extenders into the care model, and because of the increased touches, and that was really key for me, that the patient was going to have an enhanced experience like none other. So that was very, very critical to my positioning for us to get this pilot at Heartland. The finance folks, were a little slow to that party adoption, right? So, because show me the money, promise me this, and show me the money. Because I always feel like if you go out on the quality journey first, you do what's right, the savings are going to follow that. But go out by doing what's right. So we had to kind of compromise a little bit. Okay, show the deliverables. So we went back and have a very, very compelling ROI. That will obviously decrease the cost of care and improve quality. So we hope to, hope is not a plan, we will deploy this. We'll be ready by the January of this next coming year. We've already started to do some of the beginning groundwork. We will be using LPNs on our care team. There is a local community college that does have an LPN program. Primarily, they have been employed in SNFs. So we really believe that this is going to be a new way. We believe that the LPNs would be welcomed to welcome the opportunity to return to the hospital and truly employ them in a model that helps them work at the top of their license and not just have the LPN be glorified techs, which I think that they get sandwiched into being in a lot of cases. So we're going to be proud to have them back on the care team. We're going to put them in their own color uniform. For the few LPNs that we have them in the same color as the RNs. I don't get that. Make them proud to be LPNs, let them be able to explain to the patient, what their role is as a member of their care team. So we're very, very excited, and hopefully we can come back and tell you what our results are next year. We'll see. Thank you.
Good afternoon, my name is Jennifer Woods. I am the Chief Nursing Officer of McLaren Northern Michigan. So McLaren Northern Michigan being a subsidiary of a larger system of 11 hospitals throughout central and western Michigan. I'd like to think of us kind of as the subsidiary that could, the little engine, and as a subsidiary being rather innovative. As Carol was saying, there's a difference between performance improvement and innovation. I think, listening to that today, we're actually really innovative. We oftentimes call it process improvement because we're trying to solve problems and think of it in that context, but there's a lot of ways that we're innovative, and I think this is just one more way to address some issues. For me, it really comes back to, there's a lot of synergies with these ladies on the panel, and we only just met. But for me, it was an opportunity given by my CEO as well. I had been out, met our BANYAN friends, and he came back and said, there may be something here, just take a look at it. Hadn't really even delved into nursing specifically, but was looking at all the other areas, with surgical services, procedural areas, and maybe there's a way to be innovative there. Once I met with Cindy and her team, I was all over the possibilities. It was like, whoa, we can have some big impact here, and really had to draw it back. In my assessment, the biggest first impact, it needed to be with nursing. It comes back to what do I lose sleep over? It's my nurses. What do they lose sleep over? Their patients. And not being able to spend the time with their patients in the way that brought them into the practice in the first place. So if we started there, how could we implement something like this and make a difference? I knew and have been wringing my hands over this for a long time about we can't keep doing what we're doing and get different results, right? But what's a solution? What's a solution? And trying to figure out how we can go about modeling differently. We are a BANYAN hospital, so I'm very proud of our nurses. They are innovative, they think differently. One of our units was looking at different models on that unit for that population. How can we partner with our patient care techs to do assignments differently, and had gone out and done the research. And there's not a lot of solutions out there. We're still doing a lot of what we've always done and trying to get different results. I could see the quality impact of this, but again, our HCAP scores were really good. Our quality outcomes are really good. So whatever we did, we want to improve on that, but we certainly don't want to backslide. So for me, it really came down to how can this impact our nursing care delivery and also that interdisciplinary team, because on any survey, communication is a top issue, at least it is in my house, I don't know about yours. But, and so how does the interdisciplinary team communicate around the patient care? How are we sure that we're doing the best for that patient throughout the continuum? And the introduction of a virtual nurse and being clear about what their work will be, how they're complementing the team, how we can proactively communicate amongst ourselves throughout that care continuum was just really intriguing to me. So we are at the very beginning of our journey, very much kind of the same timeline, looking at implementation, really probably around January. But part of that work and what I'm really excited to do with BANYAN is to do that planning. Do that planning with my nurses and say, okay, what pieces are most meaningful for that virtual nurse to do? How can they complement the work of the direct care nurse? And then once we've kind of proven that out, look at how is this going to affect our physicians. I was having a conversation last night at a little gathering, and I worry about my physicians as well, honestly. The demand on them and their time, and how can we innovate and make the most of their time where they need to be? How can they be with the patients when the nurse is with the patient, or when the case manager is with the patient? How can we connect to the team and improve on that communication and really grow that interdisciplinary team? Or being innovative along those lines too. I thought it was really intriguing what Carol said today in terms of reporting structures at that unit level. We've explored the ideas of that co-leadership, physician and nurse at a unit level, but really having that whole team reporting to a single, probably nurse manager for that to align all of their expertise around the patient population is really intriguing. But adding the virtual nurse into that is certainly a possibility and can help facilitate that. So that's us in a nutshell. That was my motivation. I've got my team with me here today that are really exploring all the possibilities, and I know with the impact on the direct care, we're going to come up with something really awesome, and I just fully anticipate that this will have an organization-wide impact in the future. So really excited to partner.
I believe you all have questions.
Cindy gave us some questions to ask each other, and I really want to ask everybody to reflect. As we ask the questions and we give our answers, how would you answer the question, and how does it apply to what you're doing or not doing in your own clinical settings? So the first question I'm going to ask is, what led you to seek change?
I already alluded to that somewhat, nursing shortage. But quite frankly, for me, I've been a nurse since 1982, and I never remember a time when we had too many nurses. And I doubt that when I retire, we'll have too many nurses. And so what really I've seen, the success around has been innovation all those years, whether it's through total patient care, whether it's through teaming and care pairs. All those care models at first worked, but what didn't sustain was the ability to do so at lower cost. We were always asking for more. And I guess the finance side of me always continues to come out. And I was an accountant before I was a nurse. And I believe for us to be successful, we have to lower the cost curve. And we have to close the gap between high costs of care and drive quality above that. And I believe there's no shame in saying we need more people to do that at lower costs, and we do that as a team. And we pull our physician partners into those solutions because they're running around as short-staffed as we are. And as we start to redesign care models that really make sense for the patient, not only in the hospital, but beyond the walls of the hospital, primary care, care managers, all of those people that touch our patients have to align, and using virtual care is a solution to do that.
For me, many of the same, but primarily to stabilize the nursing workforce at this one hospital, because if we can change the complement of the care team, add in LPNs, we're going to rely less on RNs, and then really shift that RN scope of practice to have them, work at the top of their license. But another thing that was on my mind about this is, we have an aging nursing workforce. So, I'm 35 years in, and I worked half of my career in a medical ICU. I could not be working 14 hours at my age. I don't know about any of you. But, we're losing a lot of our most experienced, knowledgeable nurses because physically they may not be able to, pull those 14-hour shifts. And I just also see the opportunity for the virtual nursing role to perhaps keep that experience still working and, having them, knowledge transfer all of their years onto the next generation of nurses. So.
Yeah, those are all good points, and actually motivators from myself as well. We have, we're probably under the national average in terms of turnover and vacancy. However, it's still really 9–10% for us, which we feel it. It's significant. And the replacement using traveler nurses, we've had some great nurses that come to the organization and have done a great job and been part of our team. That said, it's not a sustainable model. The cost, to your point, we just cannot do that. And continue that. And I have to say, I've been pleased that my CEO has supported that as an option, and that it's lessened our burden, particularly in our hospital. It's very seasonal. We have a lot of tourists coming, and we love them. They come in the summer, but it doubles our population, and it's really a big swing for us to be able to handle that. But to your point earlier, not only filling those vacancies or figuring out a different model that lessens that burden, but also keeping our nurses in the workforce. Absolutely. We have a fair amount of longevity. We celebrate every year. We were talking about this the other night with my team. 40 years employees at my organization, and it just stuns me every year that we have one or two at the table that have had 40 years. So there is longevity there, and even within nursing, there's that knowledge that it will be leaving our profession, and how can I retain them and help grow? Because with our recruitment, we are a rural hospital, community hospital, do a lot of specialty care and offer a lot of great services, but nonetheless, it's hard to recruit. Housing in our area, the cost of housing is an issue. There's not a lot of it at the right price. It's kind of something you don't want or something you can't afford. So we have our community challenges there, but it does impact our recruitment. So we're recruiting, but it takes longer periods, and how are we handling that? And really trying to figure out a way to retain our nurses, their knowledge, support the recruitment of our new graduate nurses. We have, really that's what we're hiring at this point largely. And they're early in their practice. How do we not lose them because we're bringing them into an environment that they're not feeling well supported? How do we keep an eye on their clinical practice so something doesn't happen to the patient or to them and now they're done? So really trying to maximize all those things, much like you all are doing in a model that can accomplish all of those things.
I actually think they've answered all the questions on the paper. So at this point, if it's okay with the panel, I'd like to open it up to the audience for question and answer.
Thank you, ladies, for your time and your experience and your stories. I have a question I'm asking from a magnet lens. First of all, excuse my unknowingness, are the virtual nurses BANYAN employees or your employees?
Ours.
So, from a magnet perspective, and the BSN requirement, are you requiring that as well?
Yes.
I'd like to also mention that there was an article published in Jonah, and it was published by AACN or ACC, I always get all my letters mixed up, and the Magnet folks. And basically it talked about the BSN RN, and not that you had to have an all RN staff, but that there was a BSN RN overlooking that care and how to actually incorporate LPNs and CNAs appropriately into your case mix. We're Magnet, we're going for our 4-3 designation, and that was actually a wall we ran into, was how do we bring LPNs on and still keep our Magnet status? I would also mention we partnered with Creighton University, and our virtual nurses all need their masters. And they're going through the CNL program, the clinical nurse leader. So they're system generalists, quality, communication conflict specialists based on their education they're getting through Creighton University. So we have every intention of redesignating with Magnet next year, and you can use a lot of different people if that bachelor's nurse is overseeing the care.
Thank you.
I guess this question actually goes to Linda. With having a virtual nurse, has it allowed you to reduce or maintain your PRN pool of nurses?
Our PRN pool of nurses.
Yeah.
The virtual nurse really at this point in time is not tied to our PRN, but we have a very robust resource pool. And one of the things as Cammie was building her team and hiring her team, we cross-trained our float nurses to work on the floor, and some are actually virtual nurses as well. So if someone calls in sick in the virtual room or at the bedside, they already have been trained into the new care model. So as far as PRN, not so much a direct correlation there.
Okay. And I believe Dr. McGinnis talked about LPNs for the most part. And I want to know, in this particular model, for critical patients or patients who need a rapid response team, how does the virtual nurse play into that?
So we haven't.
When does an LPN care for?
So, because the LPN is one member of the care team, so the care team will be modeled as these folks have. It would be an RN, an LPN, a nurse tech, physically on the floor, and then the virtual nurse is a virtual. So however you would, early recognition, you would deploy your rapid response team. I think that certainly the virtual nurse can be part of the rapid response team and do some documentation. And Cammie, you have the answer.
Our virtual nurses attend our RRTs, and it's been very beneficial. That's been one of our physician satisfiers, is if they're in the middle of the RRT, the virtual has the chart open, she can tell what their potassium was, what their last ABGs were. She can put orders in while they're doing the RRT so that we can get some orders implemented in the meantime.
Okay, I just have one more question. This is from a cost standpoint. It appears that the virtual nurse, you're actually reducing the RN cost at the bedside because you're expanding the number of patients to one nurse. So have you had to reduce your staff in order to accomplish that?
Well, actually, again, the number of staff are higher. It's the component of skill that's different. And so for us, with the paramedics, their salary is very identical to the LPN. But we chose paramedics because of the fact we are a critical care hospital, and we do have a high complexity in all of our hospitals. So what we're finding, I just wanted to answer back to your former question, quite honestly, it's almost embarrassing, but the paramedics are identifying early signs of septicemia. They are identifying declining conditions before the bedside nurses. So they're actually teaching a higher level of critical care through their